So just by a little show of hands, how many people are familiar with EthOss or have used EthOss clinically? There you go. Nearly half. Nearly half of all of us have had a go, use it. How many of us are using it regularly? A few hands again. So when we have these speakers, local speakers in the afternoon, I'm looking forward to learning some bits and pieces from you as well. It's always interesting coming further afield and seeing how everybody starts to put their own little angle on the material and use it, and we see benefits that way as well. So thank you again, Khan and Holiday and Dental Space for organising this. If we just start. So moving through, this is my first time to Thailand and Bangkok, so thank you very much for having me. So just touching on sort of where my journey started with EthOss. It was in 2015. It was my sort of first trip abroad, dental trip, associated medical research trip. And this was when we went to Athens to do a study at the university to see if the material was osteoinductive. And the way we did that was by implanting little bits of the material into rabbits' muscles to see if over a period of 6 weeks that material would start to turn over into the precursor to bone, which is osteoid. So this image on the left is from histology. Those are white granules, are little bits of EthOss. Just here, there's a little bit there of osteoid, which is the precursor to bone. So these are some results that showed us that we can start to generate bone in areas away from bone, which is the sort of classic indicator that it's not just osteoconductive, but also osteoinductive as well. So you might wonder why we've got a newt on the screen, but it really all comes down to do with regeneration and regeneration potential. Now, newts have a phenomenal ability to regenerate. Some of you may be just get comfortable with that. Yeah, so these little reptiles have an incredible ability to heal and regenerate. And we all know that if they lose their tail, they can regrow back. But what we didn't know, or I didn't know, was that they can do it with any part of their body. So if they lose their eye or an organ or a limb, there are messages within the body that allow it to regenerate. So the regeneration potential is excellent. And if it is to lose a limb or an arm over a period of 120 days, it can essentially grow on back. So this is what regeneration is really all about. And in dentistry, usually we are replacing rather than regenerating. So having the opportunity to regenerate tissue, having the opportunity to regenerate tissue rather than just replace is what it's all about. So unfortunately, if we lose a limb, we can't simply wait for it to grow back. But that doesn't mean we don't have a healing potential. So the healing potential, regeneration potential that we have ourselves is still slow. We still have to wait. But essentially, the body has the ability to repair a defect. Not quite to the same extent as a newt, but we do have the ability to heal. So soft tissue can regenerate and heal. That's the same with bones, especially in younger patients. We have an increased healing potential. So with this healing potential that we do have, why do we need regenerative medicine and regenerative procedures in dentistry? And the reason is because when the defect is small, we can rely on our own healing potential, but when the defect increases in size, we need to give that healing potential a little bit of a boost and a little bit of extra help. And traditionally, Some of the materials that we've used, and often considered the gold standard, is autogenous bone, that which is taken from our own body ourselves. One of the issues with this is there's a limited size of material that we can take, and another issue is site mobility, so that with time we can have difficulty in the areas where we've actually taken the material from. And it's unusual to think that we try and treat one area by causing damage somewhere else. That's still working? Still good. So the other thing is, with age, we also lose healing potential. So as we get older, the body's ability to heal reduces. In order to manage our patients across time, we need materials that are easy to use, that we have to hand, that we don't have to put a lot of time into accessing. So synthetic materials are excellent because we can have them easy to store, easy to hand, they're easy to access. And with these materials now, we're now getting to the point, particularly with beta tricalcium phosphate and calcium sulfate, that we are seeing an optimization in upregulating host healing. So we are now finding that we can really boost healing better than we can get healing to a being just with our own bone alone. So some of these signals that we get from this material are causing our bone to heal better than it would with its own bone. These are just some slides. Put these in. These were taken 2 years ago, 3 years ago? 2 years, 3 years ago. Peter gave me these last week when he knew you were talking as well. And it's always nice seeing slides from other clinicians because it just reaffirms what we're doing, and it sort of just it's nice to see from other people's perspectives as well. So really, what is this sort of regeneration potential that we're creating? Regeneration potential is there we go. So the regeneration potential is really how do we manage a defect like this, improve the site, whilst doing it all minimally invasive and easily. So this is a patient that's coming, defect on that side, upper right 6. When that tooth comes out, there's going to be an area that if we allow and let it to heal on its own, we're going to end up with an area that's more difficult to manage over the long term. So you can see when that comes out, the area is going to be difficult to manage. So let me just show you how we've managed it with EthOss. That blue arrows stipulate on the screen where the EthOss is, where it's gone to, and you can see in just 10 weeks that EthOss turns over and we're left with a nice residual ridge, which is far easier for us to manage than if we'd taken that tooth out and just hoped for it to heal. So part of this process is regeneration, but it's also managing our patients and creating more efficiency by using host healing and encouraging host healing to work with us and work for us. So another case here that just demonstrates what it is that the material can do. A sort of moderate defect there where a tooth has come out, we've lost a little bit of that buccal concavity. We know that if we just place an implant here, the soft tissue isn't going to look well. So when we open it up and we've cleaned it and degranulated it, so on the left hand side, that's a nice clean site. You can see once our implant goes into this defect, buccal defect is showing at least 6, 7, 8 threads. So we need something to put over that so that when we close it, we can close it and allow the body to heal and allow for the bone to turn over. We do that by placing the material over the top, and this is an example of where I've used a slightly drier mix just to give us a little bit more stability. We'll go through the sort of drier, wetter mixes later. But you can see all I'm doing there is applying the material, beta tricalcium phosphate, calcium sulfate, directly onto the surface of the implant. This is taking in total about 3 or 4 minutes. It's a very easy, quick procedure at the end of the implant going in. I'm not overfilling the area, just putting enough in, because the thing that we actually get with beta-trial calcium phosphate, calcium sulfate EthOss is that it just about all turns over, so we don't need to overfill it like we used to with traditional grafting materials. So we then close up and we just wait 10 weeks. And you can see already this area is looking a lot better than it did before we started. And that's because we've directed and encouraged host healing. So here we are, 10 weeks later, we're at second stage appointment, and this is really the uncovery appointment. So we raise the flap, and we basically just place the healing abutment on top, and you can see here, we're looking at a ridge where we're going to have to try and find the implant because it's sitting underneath bone. So this is always a good problem to have. And if we just remember what it looked like 10 weeks ago, we can see how far it's come. And a lot of this is down to the sort of regenerative potential that the body already has, but how the material allows us to use the regenerative potential and get the most out of it. So if we just run through and remember what it looked like 10 weeks ago, once we put the EthOss on top, you can see really through not overfilling it and just contouring it across the top, letting it set, we've created the perfect environment for the body to do what it wants to do, and that's to settle and heal. And there's the soft tissue just over the top again. And I mentioned I've used a slightly dry mix. So just to touch on it briefly, a dry mix really just involves a little bit less saline. Saline is what we use to hydrate the material. You're adding a little bit, just enough, and you know you've got a dry mix where you can turn your peroxide elevator upside down and it just sort of hangs on. And that really just gives a little bit more stability in some of these defects, some of these voids when we're placing it. So as well, so this is really true bone regeneration. We're not using any membranes, so we're not inhibiting host healing by putting a sort of little sheet of PICC membrane in between the bone and the periosteum. We're using the bone and the calcium channels and the signals to upregulate the healing, and we're doing all of that in 10 weeks. So there we are, trying to find the cover screw so that we can access it and put the healing button on. And here we just have a series of radiographs, and we can see from beginning to 10 weeks where we've started. We've got quite a sort of radiolucency. We use a lot of periapicals for our surgery, so you can see not a lot of thickness of bone. And then where we are 10 weeks later, you can see over the top, almost looks like there's some what we might call residual graft, but the beta-tricalcium phosphate resorbs incredibly quickly and turns over into bone. So what we tend to see is a sort of denser bone with a little bit less connective tissue. That's one of the things that EthOss gives us, is a denser mineralized bone with less connective tissue element in it. So it sometimes appears that we can see it at that 10-week point. So here is the healing abutment just going on, and you can see that nice contour of buccal bone that we didn't have beforehand on the outside there, and then just over the top. Of course, we put a little bit of blue M gel on. When we're doing lots of little bits of oral surgery and working with new native bone, we want to protect it at every opportunity. And the blue M is just a oxygenating gel that supplies and delivers oxygen, and one has a function of helping to kill any bacteria in a fairly non-aggressive way. So I have a preference to using this over something like fluorhexidine because it's a bit aggressive to use all the time. And it also encourages host healing by delivering oxygen and allowing proliferation of blood cells and letting things heal a little quicker. So there we go, a review of that. We can see that defect that's improved, and that's fit and loading the implant at 12 weeks. So you go from this position, 0 to 10 weeks, and then on to fit 2 weeks after, very easily. This is one of the key aspects to this treatment, is it takes very little effort on my behalf. The surgical skill and the understanding of using the material can be sort of learned very quickly, and then when we apply those skills in clinic, I find this is a very easy material to use and to get good results. The handling, there is a slight learning curve, but once you get through that learning curve, it's working very well. So generally we have what we call the published protocol, which I'm going to go through with you now. This is what was published in 2015, and back then we called it the Simplified Regeneration Protocol. And it was a 10-year review of about 500 grafts. And the protocol was straightforward. It was just taking the tooth out, letting the site settle and heal for 5 weeks, then going and placing your implant, letting it settle, heal for 10 weeks after that, and then coming back and activating that implant at that 10-week point, and fitting and loading your crown 2 weeks after that. So what were the reasons why this published protocol simplified regeneration technique makes sense? One is because it's making best use and directing host healing to try and work with us. So we take the tooth out, and one of the great things that we used in our favour is the fact that bone tissue, so hard tissue of the mouth, and soft tissue has different progressive rates of healing. We use that to our advantage because we access the site at 5 weeks, which is the perfect time because we've allowed enough time for soft tissue to mature and grow over the top, but the bone and the hard tissue underneath hasn't started to resorb or change shape, change position. So we very rarely are doing soft tissue work because we're finding we're not needing to because the sites have sort of healed so well for us. And lots of little tricks and things, techniques that we use to use the soft tissue in the area rather than taking it from anywhere else and applying it. So a little video here, just to give you an insight into what we call the simplified regeneration technique. So about 5 to 6 weeks after extraction, you can see that initial incision is going quite palpable. And then we go for a papilla sparing incision. So we have a preference for this because it just keeps those papilla in the right place, in the same place. And it's a less invasive technique. It's very unusual for anyone to come back and say they've had any discomfort. Most of the time patients are coming in and saying, wow, I spoke to my mum or my sister or my friend and they couldn't believe that there was no discomfort. So we know with these techniques we are less invasive and the materials work so well with the body that there's no reaction. So one of the key points is cleaning. If we don't have clean bone or bleeding bone, we need to degranulate it and get all the granulation tissue out so that we can. So you can see here as well, this is a prosthetically driven planned placement, but we haven't got any bone there, so we're going to put the implant where we want it to be, and then build the bone around where we need that implant to be. So this is immediate grafting and immediate placement in terms of doing the two together. So, nice clean site, place the implant, apical engagement, just enough stability. That's probably talking out at about 20-25 Newton centimetre, which is plenty of stability. Cover screw goes on, and then this is a closed healing technique. So plenty of that implant is still uncovered. So this is the same line going into the EthOss. And we're going to go through mixing techniques later on. And then just applying the EthOss over the top, contouring it on. And you notice how quick and easy this is. It really does take just a few minutes. There we go, so stable set. So that gauze has been held down there for about 1.5 to 2 minutes. And then we go for a nice closure. And again, it's a tension-free closure. One of the things that I want you to notice here is how we use the position of that incision that's just a little bit plagal to our advantage. And the increased volume on the buckle, we basically let it heal by secondary tension just a little bit on the inside. So I'll show you when we get through to that point. So it's nearly primary closure. If we get primary closure, I'm always happy with that, but if I have to rely on a little bit of secondary tension healing on that plagal side, I'm happy with that as well. So you can just see a little bit of a space at the bottom, but I don't put too much tension on this. I want it to be quite relaxed. So the protocol's been published many times, and it's what's worked, but as this was 2015, times have changed a little, and we have started using the EthOss in different ways as well. But just to reiterate, this is just a simple case that reiterates and goes through and shows why it's still a good technique. So this tooth that we can't place an immediate on, or my preference isn't to place an immediate with that apical infection. So we go through, take the tooth out. My routine for looking after extraction sockets is just to place a little collagen sponge and a horizontal cross-mattress suture over the top. Just find it gives a nice sort of controlled healing response, and this is an example of one case where we've done that. Tooth come out, and a little dentures going over the top. So this is really the most important slide when it comes to understanding simplified regeneration and why we go for that early delayed approach. So this is 5 weeks worth of healing on the left hand side and 5 weeks worth of healing on the right hand side. So on the left we've got all this beautiful keratinized soft tissue that we're going to use the periosteum under that to encourage healing of the EthOss. But on the right hand side we've still got some of this bony sort of scaffold where the bone's been. It's not started to resorb or change shape yet at 5 weeks. So it's really nice time to go in. And we go in and we place our implant, and we place the EthOss over the top. And then we close up, and then we just let it set and heal for 10 weeks. And here we are, nice soft tissue, nice development, nice placement, and nice position. So a slight tweak on that simplified regeneration protocol is when we use other little tools that have become sort of mainstays in our daily practice, and one of them is the Cervico customized healing abutment. But this is an example of a case in which we've really used the body's ability to heal, but directed it and just pushed it off in the right direction using the EthOss and the custom healing abutment. We've got a really nice outcome and result. So this case on the right, so all I've done here is one appointment taking the tooth out, and the second surgical appointment was placing the implant in the custom healing abutment. And through doing those two procedures, we've managed to create a nice soft tissue and a nice emergence profile for that buccal soft tissue. Does anybody know what the Cervico custom healing abutment is? It's just a sort of matrix that we use to generate a nice contour and shape specifically for a site in the mouth. And there's this circular dial, and you use that just to give you a nice healing abutment that fits the space that you're working with exactly. And this is an example of the surgical procedure. So we've waited 6 weeks after that tooth come out. In this case, it was a deciduous E, so a baby tooth that had come out, so that gives us the added advantage of it being an easy placement. But you can see, cycling through these photos, the first one at the top, really nice soft tissue after that tooth come out. Place our implants in the middle, and then we place our customized healing abutment. And this is where the custom healing abutment and the EthOss work really well together. And the soft tissue that we've taken off the top of the ridge, we move it onto the buccal, and that's how we get that nice buccal contour. Without doing any soft tissue grafting, we've managed to give us that nice soft tissue outcome. When we look at these, when we take the crowns off, you see the sort of red, almost looks a little sore, but there's a big difference between a little bit of redness there and inflammation. That's not a good thing. This little bit of redness that we see on the inside is an indication that we've had heavy desmosomal attachment to the underside of our custom healing abutment. Now that is our biological width. So that's what's protecting our implant underneath. So that is a good thing to see. That's what I want to see. And there we go. That's how we generate a nice single implant crown. That's a monolithic zirconia crown. And we've got that nice soft tissue contour on the outside. We've come from here to here. So a little bit of background running through the sort of biology that's being affected when we use these materials and when we work on the bone and the body. So we're using bone, something that as dentists we know a little bit about, but not everything there is to know. Just as a sort of interesting point, does anybody know what percentage of your body weight is made up by bone? I'll go. If anybody wants to just shout out an answer and guess, go for it. So percentage of your body weight is made of bone. Remember, bone is responsible for holding you up, protecting your vital organs, and it's an attachment for all your muscles as well. So I'm going to give you the answer, but anybody just shout out. Don't worry about getting it wrong. Any guesses? 50%? 5%? Let's go for what? Joe, what would you get? In fact, Joe and Holiday already know the answer, so I can't really ask the answer. 20%. 20% is a good estimation. Let's get one more. Anybody else think anything around 20% for total body weight comprised of bone? Let's go for one more before we move on to the next slide. 40. So we're going higher. Anybody want to go higher or lower than 40? Feel like an auctioneer now. Okay. Let me give you the answer because it's quite impressive that it is such a small figure. So these are statistics for my body, and only 4% of my body weight comprises of bone. So from that we interpret that we're getting a huge amount of value from something that really weighs so little. So bone is far more impressive and intriguing than we often give it credit for. By contrast, if we look through the rest of the weight of my body, you can see my left arm comprises the same amount of weight. The muscle in my left arm, comprises the same amount of weight as the rest of my body's bone does. It's interesting that we get so much from something that weighs so little. So when we look at the breakdown of this impressive material bone that's living inside of us, we have to recognize that it is not homogeneous. It's completely varied in its consistencies and its qualities throughout the body. And different parts of the body bone is completely different. And that's true for mandibular bone and maxillary bone. They may as well be opposite ends of the body for how different the bone is and how differently it can behave. So if we look at the breakdown, we've got trabecular bone, we've got cortical bone. And if we look at some histological slides, you can see the trabecular bone has far less osteocytes, sort of bone cells, than the cortical bone, which is very dense, lamellar bone, which is what gives our bone its strength. So there's, at the bottom there, another view of what bone looks like under close examination. And bone is under this constant state of turning over. Sort of every 100 to 200 days, bone cells turn over. So we know that bone is a much slower moving material than other cells in our body. We all know that we shed and lose skin cells every sort of 5, 6, 7 days. That comes off as dust. And bone is doing a similar thing, but it's just doing it much slower. So this is a nice slide because it really shows us exactly what goes on in this remodeling cycle. So we've got an activation, resorption and formation sequence. And just across this one slide, we can see these cells working together. On the left of this slide here, we've got this sort of activation sequence. We've got osteoclasts forming a rough border. We've then got some of the precursor to osteoblasts here in the sort of resorption phase. We've then got some osteoblasts that are generating some osteoid. This little bit of all the blue in the middle is bone, and that little layer across the top is the osteoid, which is forming into bone. And then we've got osteocytes, which are the osteoblasts, which then form and sit inside the bone. So when we understand these principles, we can start to try and direct them. And this is the sort of position that we've got to with EthOss now. It's signaling to the body to heal and promote that healing to go faster. So it's an upregulation of that host healing response. So bone is very much a living, dynamic tissue, and it's regulated by things like stress and strain and function. And we know that astronauts who go up into space and spend a lot of time there have to do a lot of exercise to try and maintain their bone density. So they are losing bone strength and bone density because there is less stress and strain. And this all relates to Wolff's law, which was put into place about 125 years ago, and that is the idea that healthy bones will adapt to stresses and strains. They have a fitness that adapts to their environment. So we've got the astronauts that are losing bone density and can't spend too much time in space. And then we've got tennis players that, because they're moving around very quickly, there's a lot of impact, their bones build up and they are stronger and more dense. So we see it in dentistry as well. So these implants that were placed 26 years ago have got this beautiful osteocondensation around the implant. You can see really how that trabecular bone has just continued to turn over. And we know from histological studies that have looked at implants in humans that that bone can continue to mature up until about 21 years after an implant's gone in. So when we place implants, we wait that 10 weeks for what we call clinical integration. But those stresses and strains on the bone keep encouraging it to mature up until 21 years after the bone has gone in. So bone being this incredible material, which we need to exert stress and strain on it to keep it, if we don't, we start to lose it. And we see that in extraction sites, where teeth have come out and bone has been lost over time. So this stress and strain that's provided through to that alveolar bone through the tooth is what's been keeping those bony peaks there. And we see over a period of a year how much bone we can lose because there's no stress or strain being exerted on that bone. So when we want to rebuild the alveolar bone, we really have to first understand it and understand what's there. We've got the bundle bone, the trabecular bone, and then underneath that we've got the mandibular and maxillary bone. So if we lose the tooth, we very quickly lose that alveolar bone because there's no requirement for it to be there. Your bone is a calcium bank for the rest of the body, and if there's no need for any bone to be there, the body simply thinks, I don't need the bone, let's resorb the calcium and put it somewhere else. So if we look at alveolar bone and the sort of incidental peaks that we see between our teeth, those are only there because of those stresses and strains that are put on the bone through everyday chewing and function. When we look at extraction sockets immediately and 6 months after a tooth has come out, we can see that there is significant bony change that is difficult for us to rebuild. So if we wait too long after we've taken the tooth out, we can rebuild a little bit, but the simplest protocol is to try and regenerate and preserve at the same time. So the anatomy of bone is also different throughout the jaws, and different things happen with time. We have different densities and different qualities. And we see these when we look at CBCTs. So when we look at an image of a site that we're about to use, we can tell the differences between these. And this was a case that we treated a few years ago. But the CBC is nice because it just gives you an image of the difference in density between the mandible and the maxilla. Mandible is going through mandibular flex, so there's sort of constant stress and strain coming through it. So we have far more dense bone, especially cortical lamellar bone down on the bottom, than we do in the maxilla, which is really just sort of still and steady because it's connected to the base of the skull. So moving on to bone grafting and materials and how we select them. This is sort of simplified division of categories, but we've got an autogenous synthetic bovine allograft. And when we are selecting materials, one of the things that we want to look at is the material resorbable or non-resorbable? And when we're really talking about regeneration, we're talking about giving the body the opportunity to build back the way it was. Similar to the newt that can build or grow back his arm in about 120 days, we want to give bone the right sort of environment to be able to regenerate without leaving anything there that stays there. So we look at resorption time. Resorption time, we want these materials to be able to resorb at the same rate as bone grows. Now, bone tends to grow at about 2 or 3 micrometers a day. So we want a material that resorbs at a similar rate. And what type of cellular response do we get? Because that has an impact on how bone turns over. But really, clinically, some of the main points when we're choosing our graft material is what quality and quantity of bone will we have when we come to place an implant? Specifically, what percentage of vital bone will be there at the time of implant placement? That's healthy bone that's alive, that bleeds, that behaves like a nice dense cortical lamellar bone that can take physiological stress and strain. And how much bone there is after integration of our implant, and how much vital bone there will be to look after the site. So really it's the bottom 3 that really are the important categories here for us clinically. So what are the ideal characteristics as well when we look at these materials? We want them to be easy to handle. We don't want them to be too difficult. Lots of materials that I've used in the past that have needed tacks and sutures have taken me nearly twice as long. Or materials, autogenous, increased surgical time, where I'm spending a lot of time taking a little bone, causing the one defect to treat another. It's far easier having a material that I can just use very quickly and rapidly. So stability as well. We want our grafts to have compressibility strength so that it can resist things that go on in the mouth. Biocompatibility, of course, we need it to be able to work with the body and have no response. That's one absolute benefit of using synthetics. And porosity as well. We need there to be space for blood vessels to be able to grow inside. And that's one of the real nice things about using the biphasic calcium phosphate and calcium sulfate and beta-tricalcium phosphate, is it gives us that benefit of 2 materials in one, which is really why EthOss is very different to all the other materials. So simplicity, it's very easy to use. There's no membrane, it's very quick. It's almost a disappointing end to surgery. There's a small part of me that used to enjoy something that was quite difficult, took half an hour. Using the EthOss is really just a 2 or 3 minutes end of surgery procedure. Very easy to do, very easy to complete. Healing time, we can re-enter at 10 weeks. So whether I'm using it for a single tooth like I've shown before, or I'm using it as part of a full arch treatment, rather than waiting up to 6 months, I'm now going in categorically 10 weeks. The studies and the data and the science shows us that we could go in at 8 weeks, but it's nice just to build in a 2-week contingency because everybody's healing potential is a little different. So we don't want to just go in too soon. So it's safe, there's no issue of any cross-contamination. This has been an issue for autogenous in the past, many years ago, issues with that. And as I've said before, it's very easy, very quick to use. And it's strong. So 50% new bone at 10 to 12 weeks, coming in from our histological studies. So yeah, there's many other different gels, systems, xenografts or membranes. So we're lucky that the host heals and the host wants to heal. But if we don't direct it and encourage it in the right way, we won't get as good healing as we could have. So it's the biphasic matrix nature of the beta-TCP calcium sulfate that makes it work so well. So a little bit about the calcium sulfate. In the mix, we've got 65% beta-tricalcium phosphate and 35% calcium sulfate. It's really this mix that gives us the great results. But it's also the porosity of these two as well. So the way in which they're manufactured, different temperatures give us different sized granules, and it's these little things that have an impact on how well it works. So the calcium sulfate really plays the role of the barrier membrane, and it does that by creating stability, but then resorbing back in about 3-4 weeks to give space for angiogenesis. So just put this in because it's interesting, because a couple of these authors are sort of strident xenograft users. But if we look through the list of sort of recommendations for what you should get from a grafting material, the fourth on the list is totally replaced by bone. And we know, even though xenografts work, they aren't totally replaced by bone. They turn over very, very slowly, and you get a limited volume and amount of vital host bone in them at that. So really, we see our mix of EthOss as being the only one that really fills all of these criteria. And beta-TCP and bone is being studied since about the year 2000. There's a lot of orthopedic research and bone physiology research going into looking at how this works behaves with bone. And a lot of the research around EthOss now isn't coming from us, it's coming from other groups. This was a study that was just done recently in Egypt, and it showed, looking at bone, so it was little bits of alveolar bone in rabbits, and it was broken down between EthOss, xenografts, and a bit of autogenous as well, looking at how well they heal and how well they respond. And essentially, EthOss came out top for delivering vital bone and looking at the healing markers as well. So if I show you a little bit about what was done, a very simple study that's done a lot, we've done one ourselves as well, is cutting these little core markers into bone and filling them with bone materials and bone products that we then want to evaluate and assess. So in this case, it was evaluated and assessed at 2 weeks and 6 weeks. And it was EthOss again coming out on top for healing markers and percentage of vital bone. So there was a demonstration as well in this case that there was a better response from the EthOss than there was from the allograft. And I'll go through now and try and give you an understanding of a bit of the science as to why that was. Okay. Okay, so some of the science. So one of the things that happens with the calcium sulfate, the beta-tricalcium phosphate, is we get free ionic calcium ions. And these calcium ions are very powerful osteoprogenitor encouragers, and they are giving very strong signals within the bones to start building new bone. So one of the things that we see is there is an inhibition of bone resorption with the material. And there is osteoinductive nature of the material. So new bone is encouraged by nature of these calcium ions. So we can see that it's a powerful material, that has the ability to build bone away from bone. That is how we define osteoinduction. It's the ability of the material to start to generate bone where there is none. So going back to that study that I showed you at the very beginning that we did in 2015 in Athens, that was where we put a little bit of material into rabbits' muscles, then come back at 6 weeks and see that it had started to turn over into the precursor to bone. So this is just a scanning electron microscope image of an osteoblast sitting on a little bit of beta-tricalcium phosphate. And what we see is the osteoblasts start to speak to each other, and they then start to follow the little bits of calcium, and it's the calcium that they use to start to direct new bone growth. So one of the things as well that we know from these orthopedic studies is that these calcium ions that are released in the material have a huge effect on the ability of the osteoblasts to start working. And just by a measure of how powerful they are, this graph shows a black slide. HOB at the bottom is human osteoblasts, and the black shows human osteoblasts when there is the correct ratio of calcium ions provided by a graft material. On the left-hand side, when there is no calcium ions provided. So, utilising the chemistry and directing healing, we can actually get a 500% boost to the osteoblast function at that point. Let's go through to look at a clinical case now. Now this is just something that I show at the beginning, and it's just something to give you an impression of what can be achieved with material. It's not a published protocol, and it's not something that's recommended, but it's something that we use from time to time, just when we need to. So here's a sort of reasonable defect. So this is 5 weeks after the tooth come out. The defect there was just too large for us to have any stability. So what we do is we place the EthOss first, and then we place the implant down into the EthOss. So there's no bone to implant contact here and no real primary stability. The only stability that we get is coming from the sort of stabilized graft. And there we are 10 weeks later. So 10 weeks later we go back in and we have to uncover it. And this is really an example of us optimizing host healing. And it's an example of the material allowing us to optimize that host healing through its turnover. We get an ISQ of 77, which is very high. And this is one that was done a long time ago. That was 1.5 years loaded. So that soft tissue it gives us a nice contour. A few radiographic reviews here. You can see at 10 weeks there's still a little bit of graft. 12 weeks. If we get to the last one there, again, having a little look through a CBCT at 2 years. So this image as well, 2 years loaded and then 3 years loaded. You can see in the middle through the CBCT slice that it's all cortical and trabecular bone around the implant. And on the right hand side, one of the features of EthOss that we see is this densification of the bone, because we're getting less of a connective tissue element to the bone when it's turned over and when it's healed. But we know from our histological studies that these sites are completely turned over into bone, even though it just looks like it's a little bit more dense. So there it is, 5 years loaded. And one of the other things with these cases, the soft tissue just tends to get better and better with time. If you look at that at 5 years loaded, and we move on to it at 8 years loaded, you can see as well, the soft tissue is still looking very good. So one of the interesting things about this case was how high the ISQ reading was. So ISQ at 10 weeks of 77 is an incredibly stable implant. And one of the reasons we get that, and it goes against what is often said in the literature about grafting and ISQ readings. So generally the consensus in literature, and this follows some original research that was done, basically says that there is a negative correlation between grafting and ISQ values. So why is it that this material that we're using is giving us the opposite? It's giving us ISQ readings that are sort of at the top layer of where we would expect them to be. So why is it that our push-in protocol is going completely past a sort of normal ISQ reading of 60, 65 or 70 and giving us a very high one of 77? But it's really all down to the fact that that bone that's being generated around the implants is just being allowed to grow and boost, and the healing is being upregulated. So because there's no pressure when the implant's gone in, we've got no dieback. We look at implants and a slide, and we sort of zoom in and look at this area. When we place implants, even with a low insertion torque, we tend to cause a little bit of pressure on the bone. And bone is a mineralized connective tissue. The other connective tissues that we have in our body, say, are muscles. But bone is mineralized, so it's harder. Even a little bit of pressure can cause a little bit of a dieback. So sometimes what we now know about the biology of integration is that often when we go for a very high initial primary stability, we're causing more pressure to the bone, and that actually could cause a sort of deintegration before we start to integrate. So what we see in that case with the push-in is, rather than being any pressure, we're just creating this site, this environment for all this bone just to start growing. And this is just an example of what happens around an implant when the bone grows through and grows in. But we're not causing any dieback. Again, a second push-in case, just to re-illustrate. So this is a fractured root that was a referral case. So a patient comes in like this. Our referring dentist sends the patient across and says, can you take the root out and place an implant at the same time? We say, not really. So we revert back to the simplified regenerative protocol of taking the root out, leaving it for 5 weeks, and then coming back to place. But after our sort of surgery and removal of the root, there isn't a lot of bone there for us to place an implant. So you can see our direction pin has just fallen into that socket without me drilling anything. So this was an implant that we placed without using any drills. So you can see we take the implant and we place the cover screw on the implant, and we use the cover screw and the hand driver to place the implant into the graft. Then close up over the top, a little bit more EthOss just over the top. Once it's covered and closed, it's the EthOss that's setting that now gives the implant the stability. And what we want to do is just check that we've got that screw channel position coming out of the right way, and then we move through. I don't have the photos from the second stage, but I'm always very sort of minimally invasive with my incisions at that point. But here we are 2 weeks after I've taken placed the healing abutment. I'm taking my impressions, and then 2 weeks later I'm going in and fitting the crown. And the interesting thing that we see here is, I did this case 2 years ago, and looking at the papilla, the mesial papilla that was sort of slightly irritated when we placed the crown, it's just got better and better. And this is something that we see all the time. The soft tissue improving around the EthOss years after we've placed it. So this is an example of true bone regeneration where we've created something that's sort of physiologically holding onto the bone, holding onto the implant. The bone's been able to turn over and respond the way that we want it to. So it's not a recommended protocol that we talk about in terms of advising you to use it. It's just something that we can use to try and learn and understand how the bone and the biology is responding. So if we go and have a little look in a bit more detail at some of the histology, so that we can have an idea of what's going on. This is just an example of an EthOss granule with new bone, sort of swallowing it and engulfing it. And some of these histology slides that come back are really quite beautiful, and this is just one of my favourite ones. But here we go. So we did a study with Frankfurt, and we did some histomorphometric analysis of the graft at 10 weeks. So if we have a little look at this, you can see everything that becomes red is new bone, and everything that is blue is EthOss. So this is where these figures come from of the approximately 50% new vital bone formed and only 8% residual bone left. Now the interesting thing about this study was about a year afterwards there was a socket preservation study done utilising xenografts by the same team. So we got a sort of direct comparison of histomorphometric analysis of EthOss versus xenografts from the same team in Frankfurt. And I'm not saying xenografts are bad, I'm just saying they're different. And they can be used for different things, but in terms of understanding how they work and they behave, it's a really nice contrast to see this because it gives us a real impression and understanding of why they are so different. So on the left, you see a core sample being taken, and on the right, you see the core sample of some xenograft. And what we're looking at is, let me move on to this one. This is the core sample, and what we're looking at is bone turnover of this material at 6 months. So when we were looking at EthOss just a minute ago, we were looking at it at 10 and 12 weeks. This is 6 months after the material has been in situ. So what we see comparatively is on the left, the bovine, the xenograft, and on the right, the synthetic. And when we put it through the histomorphometric analysis so that we can see how much new bone and residual bone is there, we see that in the xenograft, the new bone is the red, and in the EthOss on the right side, the new bone is the red as well. But we see there's far more particulate left in the xenograft, and that's essentially because it doesn't turn over and it doesn't resorb. Whereas what we want when we're using real regenerative protocols is we want what we're using to signal the regeneration to disappear, so that area of body is then left as a physiological bit of bone that behaves normally. There we go. So we're looking at 8% residual EthOss, 30% residual bovine, and 16% new bone in the bovine versus just about 50% in the synthetic. And this is true throughout the literature. This is another socket preservation type study. And what we found with the allograft was there was a 20% increase on average. The autogenous, 20% increase. Xenografts could have as much as a minus 20% effect to a 9% increase. And alloplast synthetics was around 20% as well. So what we're seeing there really is that the 20% are very similar to the autogenous and the allografts. So one of the major issues with using grafting materials that don't resorb is that they stay there and they can affect the normal turnover, or they can affect the quality of bone that's there. Sometimes we shouldn't expect the same quality from that grafted area if it's not grafted with something that's turning over physiologically. So this is an example of an implant sitting on the left next to a bovine's histology slice, and on the right next to a histological slide of EthOss. Now on the left-hand side we've got these big particles of xenograft that are sitting within the bone and affecting really how well that bone responds to stresses and strains. Whereas on the right-hand side we've got a much more sort of physiological lamellar cortical type bone that's going to withhold stress and strain far better. And if we look at these images on CBCT, we see really rather than getting a bone regeneration with xenografts, we tend to see what we might call an integration of the material. So it's brilliant for sort of preserving pontic sites where you want something that's slowly resorbing, where you want to maintain a soft tissue position. But when we look at it, for example here in a human example where a cadaver's had a sort of onlay graft with a xenograft material, we see it's just sort of integrated onto the surface and it's just held there. It's not going through a normal cycle of bone turnover. And the other interesting thing we see is how the xenografts are used in the sinus. So tend to use huge volumes of material in the sinus to try and get sort of the same response that we might get from a physiological synthetic graft, where we just encourage bone to heal. We know we don't need a tremendous amount of good quality bone around our implants, so why are we putting so much sort of bad quality bone into the sinus and then wondering why we have problems in the sinuses? So this is a huge area that's been lifted, but we could really have gotten by with a small lift and a little bit of physiological bone lifting. So this is an example of a xenograft a few years after it's gone in. That was at one review. A year or two later, that xenograft spontaneously disconnected itself from the area of initial integration and gave this patient sinus issues, and it had to be removed and managed with EthOss in the end. So if we run through and we look at a few cases. So for simplicity, I've sort of separated different cases that we do into one example of a utilisation of the material is in socket preservations. Then called the next simple augmentations, which is where I'm using the material to improve the outcome. And complex augmentations, where we're using the material in areas that, if we don't use it, we won't be able to proceed with the treatment. And again, part of that, sinus floor elevations as well. So we're getting really good results with our sinus floor elevation protocol. So when it comes to preserving sockets, really, I'm only using the material in indications where I think if I don't use it, it'll be to the detriment of the patient in the case, and I think it'll be harder to manage in the future. So it's really just to preserve what we've got when I'm taking a tooth out, and it's often in large infected sites, and it's usually when I think or I know I'm going to be placing an implant again, or I'll just use it underneath the pontic, underneath the bridge. So really the main aim as well is to preserve the socket so that I'm doing less surgery and I'm doing less damage to the patient in the front in the future again when we come to place our implant or place the new graft. So socket preservation, improving the site. This is an example of utilising the material on the right hand side. So that tooth, large infected area, once it's come out there's a large defect and void to fill. If I let it heal on its own, I might be left with an area that's more difficult to manage. This patient, in fact, she's 93. She was Christian Dior. She's French, and she was Christian Dior's first ever catwalk model. So I think for about 30 years she was the original Christian Dior model. She lives around the corner from us in Kensington, but she's ever such a nice old lady. But we went through this process of grafting the site and preserving it for us to place an implant. And in the end, she decided that she'd rather give the money that she put aside to have the implant to her 2 grandchildren. So we haven't done the implant, but it's a nice socket preservation case that I keep under review. So here you can see the socket preservation on the left, that's immediately after the material's gone in. On the right hand side here, if you take a x-ray over a week to 2 weeks, you might think, gosh, I've lost all of my graft material. But it's not the case. As the material starts to turn over, it loses that radiopacity. So as it's becoming connective tissue, osteoid, it's looking more radiolucency before it starts to become mineralized. And here we see at 8 weeks and then 12 weeks on the right hand side, you can see it's turned over nicely. We've got a nice residual site that will be relatively straightforward, easy for us to place an implant, if she ever eventually decides to have one. So we've gone from possibly having an area that's difficult to manage to having about 7 millimeters of bone, which we could either place a 7 millimeter implant, or we could do a small sinus lift when we place it, just to give us something a little longer. But there we go, a little review. So another case here as well, where we've used the EthOss to improve healing. This was the first case that I showed you, but these are just the clinical photos as well. So when we take these teeth out, we do it gently. We then completely clean the socket, the interior. I like to get all the granulation tissue out, but I also like to see some bleeding, because we need the area to bleed if it's going to heal. One of the anaesthetic that I use is articaine for my surgery. and every now and again I find the area isn't bleeding enough because the articaine and the adrenaline is very good at sort of holding that, that vasoconstriction of the adrenaline is very good at reducing the blood supply. So sometimes if the area doesn't bleed enough at that point, after I've cleaned it, I'll make a little incisions in the gum just to cause it to bleed for when I place the bone graft over the top. Once the graft is in, I place a little collagen sponge over the top, and I put a little cross-resorbable mattress suture, and that just holds everything down, and it keeps everything in place. And the important thing to note on this side with the graft in place is I haven't overgraft. The temptation when you have EthOss in your hand is to put as much of it as you can into the socket, but you want to put as enough or as much as you believe the body can heal, as much as you think the body can sort of cope with. If you put too much in and you expect too much from the healing, you can sometimes cause your graft to be lost because it's not in the right place, or it doesn't turn over as well. So it's really interesting that sometimes less is better than more. So that's the example of this case at presentation and 10 weeks after. And we went on and placed an implant there as well. So again, another socket preservation, just an indication of trying to use this material to be less invasive. And you can see both teeth here are separating. So when we've come to place this, we've really cleaned the meat of that tooth on the lower right 7. And this is what I mean by using the collagen sponge. I take the collagen sponge and I squeeze it down so that I've got essentially a little cover for what would otherwise have been a sort of open healing wound. I just like to have something over the EthOss just to cover it. Now this is a material that I'm using. It's called elemental bioplastic wound barrier. We're just running a study now to see if we get any better results when we use that over the top. It's quite nice because I know that patients aren't going to be able to sort of get any food stuck in the area or play with it with their tongue. It just gives me a little bit more control, and I quite like that. So if we look at the radiographs from immediately post-op to 10 weeks, we can see we've got some bone turning over in that side. And when we come back to look at that area 10 weeks later to place an implant, we've got a nice sort of preserved buccal contour here as well. And that's one of the benefits of using the EthOss and that barrier that I used as well. So this is just 10 weeks after that tooth come out, and you can see when we raise that flap and we start to place an implant, that entire area that 10 weeks ago was a defect and a void has been filled with EthOss and is now performing and behaving exactly like bone. Now I didn't take any histology slide, I didn't take any core samples of this, but we know from our other studies that at 10 to 12 weeks, that's 50% new bone. So the material can be applied for socket preservation. We don't want to completely fill the socket, but the real aim there is just to make your life and your patient's life easier in the future. So then let's move on and look at some simple augmentations. This is how we use it just to improve the outcome of our cases. These are the sorts of cases that I recommend using it for initially in the beginning. Part of the philosophy around using it is to try and create a little bit more bone to make my implants look and feel and be perceived more like natural teeth. That's my sort of main aim when I'm working with implants and prosthetics. I want to try and hide the fact that there's an implant there, and I find this material really helps me do that. So just using the body. If we look at a sort of immediate case, so this tooth's got a sort of cervical fracture, has to go, but it would be a shame to lose that buccal contour. Although we take the tooth out, and we have to do a sort of surgical incision to get the root because of where it is, but we can still do this as an immediate with the EthOss. So there we go, implant goes in, and again we've created one of those cervico custom healing abutments, and you can see once the EthOss goes in over the top, you can just contour it across the front, place it in, hold the dry gauze over it for 2 minutes, let it settle and set, suture it up, and then when we come back to view it 10 weeks later, we take the custom healing abutment out, we've got this beautiful contour, we've got a nice preserved bridge as well on the outside. And this is what it looks like on presentation. It's this buccal contour that I'm really particular about trying to hold on to and maintain. So we go through our sort of prosthetic appointment. And you can see when we fit our screw-retained monolithic zirconia crown, we've got that nice contour across the outside that just hides the fact that it is an implant crown. And side profile as well, this is where often our implants give us away, because we have that sort of characteristic concavity where there isn't any bone, but where there is bone, we've still got that convexity, just here. So again, when we're not preserving and we need to rebuild, we have cases where patients have been wearing dentures, and as we know, bone is a mineralized connective tissue. If we don't use it, we start to lose it. So we see when we take these dentures away, we've got these buccal defects where we've lost bone over time. This patient is one of my friends of mine who's also a dentist, but it's his mum. So he places implants as well, but he says, I don't want to place implants on my mum because I'm too worried about not doing it perfectly. Can you do it? Because I want you to do it very well. So I say yes, but we want to make sure this is a good case because it's a close friend. So in these sorts of scenarios, we want to create an environment for that patient that is easy to look after and maintain over the long term. So we come to place the material and we do a buccal veneer graft. And basically we try and build the alveolar bone out to where it has once been, so that when we put teeth in the right place, the alveolar bone is back in the right place as well, and the contour of the teeth match the soft tissue underneath it. And the soft tissue is there because the bone is there. So we build the bone out, we create volume, and we do that, and we can see that we've created a nicer profile than what we had before. So this is a case that I inherited. This is actually the example of the sinus lift on the right hand side. So we did a full arch on this patient, and we didn't utilise, or we avoided using any of that xenograft because we didn't want to or have to. But we placed 5 implants, and one of them at the front, top right, relatively slim, thin bone on the top. So again, I see an area that may be a risk in future. So I say, right, let me use EthOss to improve the site. Place a bit of EthOss over it, and we've had very good soft tissue healing and very good results. So you can see as well, gorgeous, nice soft tissue, lots of volume and space. And again, using Blue M as a material, just because we can. I use it routinely when I'm taking things on and off, just to clean and kill any bugs and bacteria that may sit there. So slightly more difficult cases where the material has a bigger impact on the outcome. This is an example of us managing some infected teeth that have come out. You see when we lift and raise the flap, this part of cleaning is incredibly important because we need to take out the granulation tissue that's there so that when we put the EthOss in, it's in direct contact with the bone. So this is an example of a TRI system implant. It's a relatively new system, and one of the nice things about these implants is that you don't need an abutment. So it reduces the cost a little, but it just simplifies the design. And the way that it works is your zirconia crown fits straight into this sort of tissue level interface, like so. So this was a case that we did. Significant volume of bone, not present there. These were very, very narrow ridges that we had to work with. So again, using the material over the top, following that protocol that I've showed you, and then getting our zirconia crowns back that fit straight to the interface. And there we go. So that's just an example of how there's no abutment there. And that's the crowns with no abutments as well. So simply just screwed in straight down onto the implant. So now moving through a few examples to show you how we use that simplified regenerative protocol to improve scenarios like this, where we've got no soft tissue across the front. What we do is we take the teeth out that need to come out, And again, we let the body do what it needs to do. So rather than overcomplicating it, we just let the body heal, and we use that soft tissue when we come back to surgery. So when we come back 5 weeks later, we find we've got a really narrow ridge. So we place our implant in the position that we need it to be prosthetically, and then we graft around that to build the bone into the position that we want it to be. So there we go, post-op radiograph, and a sequence of images that show you how we move from 1 week to 10 weeks. Now, first image, 1 week, sutures come out, then appointment 1 week later, and then 10 weeks later. Can you see how the contouring is already completely improved? We've got lots of nice soft tissue there to work with. And again, at uncovery, just using sutures again, and that's 1 week after uncovery. And then this is moving up to 5 years since we did this procedure. And you can see we've got a nice contour across the front. There we go, and before and after. So again, that's been managed in that sort of very simple way that I showed you before of us doing essentially 2 surgeries. One where we take the tooth out, let the soft tissue heal, and then come back and use that soft tissue that's healed to allow us to work in the way that we need to. And again, this patient happened to have a super CT, so we can see that it's got despite the fact that when we placed this implant there was very little, no bone there, she's now got plenty of bone over the front of the implant. So another anterior case, so utilising exactly the same sort of protocol that we just showed you. The last one, when we have these scenarios where we have soft tissue defects, the first thing we do is we just say, right, let's take the tooth out and let that soft tissue heal where it wants to heal. So once the soft tissue's healed, it's a very easy, straightforward case for us. We open up, degranulate the site, get it nice and clean. We want to really see that white bone. And then we go through the process and the protocol of placing the implant in the position where we want and need it. And you can see EthOss going in over the top. Nice little contour, little volume increase on the right hand side. And we've got some PTFE sutures there that just give us a little bit of elastic in the suture material for when things are settling and healing. And you see at 1 week, when we come to take the sutures out, we've got that little bit of secondary intention healing. Don't worry, we're alright. We didn't fall. There we go. So that's now a case that's moved through to a 5-year follow-up. And you can see you almost wouldn't recognise that she had a tooth that was sitting so proud and so far forward. So a little example of working in the posterior mandible. This is actually our nurse that we did this for. So it was interesting to see this case progress. But we went from being in a position where we couldn't place any implants for her to doing some tunnel grafting. Unfortunately, we didn't take any photos. We just got the radiographs. But it was a case where the graft that we placed initially and then came back to work with 10 weeks later allowed us to place the implants and give her functional teeth. Another case where we did something similar, I'll just show you this one because you can see how the bone turns over and changes just about. We've just drawn an image or a line across the top so that you can recognise that with the tunnel grafting, we've increased the amount of bone there, not by 10 millimetres, because that would be too much, but we've done it by 2 or 3 millimetres, which then allows us to use this space. And when we place implants again, in a case like this, we graft again. So we call it a layering technique, where we layer initially with a graft, and then we come back and layer again, where we place our implants. So a little case that we did a while ago now, but this is exactly the same as the two that I've shown you. So an area where we don't have a lot of ridge width, we don't have a lot of keratinosis tissue, we're really sort of working with minimums here, but we do exactly what we've just done before. We do a little tunnel graft. This is always a little trickier the first time you do it. So being less invasive, cutting the incision right, getting underneath the periosteum, is you need to make sure that that material is underneath the periosteum and sitting on the bone. But once we've got the material in there, we can then place an implant, and you can see already, now the implant's in, it's already looking a lot better. And at a 2-year follow-up, all of a sudden we've gone from having an area that looked difficult to place in to having an area that looks like it was well suited for replacement. So moving on to sort of sinus protocol, we've got a protocol that I'll go through now for using the material in the sinus. And this is the sort of example of a routine case where we've got 2 or 3 millimeters worth of bone. And we say, right, we want to put an implant in. So what we do is drill our osteotomy, but we do it with something called a DASC kit. A DASC kit, is anybody familiar with this? There are similar kits to this one, but this is just one that we like. It's basically a small 3 millimeter diamond covered ball, but there's hydraulic fluid that comes through the center of it through your handpiece. So when you push it up to the sinus, it's very gentle against the Schneiderian membrane. It allows me to do sinus lifts very predictably without worrying about tearing, but it's also pushing fluid through into the floor of the sinus to hydraulically lift the sinus floor. And I find when I use this, sinus lifting just becomes enjoyable because it's straightforward and easy. And what we see is we get these nice sort of domes coming over our implants. And this is a case where we've done the sinus lift, and then because we've had such good stability from this implant, we've decided to go for customized healing abutments as well at the same time. And the custom healing abutment allows us to direct the healing of the soft tissue. So these custom healing abutments, I quite like them because it's a sort of link between surgery and prosthetics. Rather than us just doing surgery and leaving it and then starting the prosthetics later on, you've already started some of the prosthetic workflow before you finish the surgery. So we get a nicer contour of soft tissue. Now when we come to place our monolithic zirconia screw-retained crown again, you can see that we've got a nice turnover of bone around the apex of that implant. And we've gone from being in a scenario where we had 2 or 3 millimeters of bone to now having 7.5, 8. And we've also managed to reduce that buccal concavity that would have given away an implant in this position. But that concavity, if you leave it there, if you place an implant crown on a concavity like that, it becomes a constant food trap for your patient. So I like to build these bits out so that we don't have that issue. So this is a little bit of crest. So when we do sinus lifts, we try and increase the volume of bone in the sinus, but we also try and increase the volume of bone at the sort of gingival, crestal, cervical level as well. In this case, just shows how when we place this implant, we've managed to do that, and to sort of build bone back a little bit in the position that it was. So we initially had about 5 millimeters worth of bone. And if you look at this green line, this is running between the CEJs and the adjacent teeth. And if we look at where it was beforehand, we didn't have that same position. So we've gone from having 5 millimeters of bone to work with to doing a sinus lift and a bit of augmentation in that cervical area, and all of a sudden we've got about 10.5 millimeters worth of bone. So the EthOss works really well when we use it with these custom healing abutments. And this is another case. So this is an example of us using the sinus lifting technique. And this is what I like to see when we've lifted the floor of the sinus. So we use that hydraulic pressure to gently lift the floor of the sinus, and we create that space to then put and push the material up into it. It just sets and solidifies really nicely. Again, I've contoured over the top of this with EthOss once I've finished, and I've gone for a closed finish in this case because the stability on that distal implant wasn't as high. But you can see on that top right hand side image where there's actually the impression of the gauze on the material. You see that sort of cross hatch? That's where we have this sterile gauze just compressed on that. and that dryness and the drying is one of the things that gives the material its stability. So you see, we now leave this for 10 weeks, we come back to look at it, and all of a sudden we've got this really nice, that dome-shaped appearance of the material is now starting to turn over. We've now got what I would call a physiological sinus lift, because it's material that's turned over into bone and it's working with us and for us. So rather than creating one of these huge, ugly sinus lifts that's made up of a lot of material that's non-functional, we've got a very functional physiological sinus lift there. And then we come and create these little custom heating compartments and place a little bit of EthOss underneath that flap and close. And what we then get is a nice soft tissue appearance that allows us to restore it with something that looks and feels more like teeth than it would do if we just placed without doing all that. And there you can see from start to finish, 12 weeks at implant fit there. You can see the example of that turnover of bone in the sinus. And there we go, that's going from having no teeth to teeth in a period of 12 weeks. So that protocol for lifting the sinus, so this is the DAS kit, that's what it looks like. This is another case where we've done an internal lift. What I'm finding now with this technique is I'm doing very few lateral lifts. I'm only really doing it, I'm just about trying every case as an internal lift. And if something doesn't quite go right during the procedure, I'll just turn it into a lateral lift. But that doesn't happen very often. So this is how that DAS kit works. Just pushes water up and it creates the space. It allows us to push the material up underneath it. And this is the only time I ever use an amalgam gun anymore. This is just a 3mm one that we had in the drawer. But it's brilliant for just pushing the EthOss up into the osteotomy. And once I push the EthOss into the osteotomy, the only thing I use the denser vertebra for is just slowly rotating it so I get that pressure and it pushing that material up into the sinus. So this is how we create this sort of nice dome type appearance. And that's how we use it in reverse. So using that vertebra in reverse has a pushing pressure and it just pushes the material gently up into the sinus. And that's how we create these nice sort of domes that when we come to place, we've got the implant sitting in a nice little bit of material. This was a referral case, so she's gone back to the referring dentist to have that restored. So this is an example of another case. Again, utilising the DASC initially, and then utilising the amalgam gun to push a little bit more material up. Then using the vertebra just to push a little bit more up, and this is just radiographic review. And then we place our implant, and we've got an implant sitting with a nice sort of encapsulated area of EthOss. On the left hand side, I think that was at suture removal about a week later. So as I mentioned before, the graft can start to look radiolucent, but really it's just it turning over into osteoid and turning over into the precursor for bone. And on the right hand side there, you see a sort of physiological bone lift that's still turning over. And we've got it before and after there. So you can see how much through sort of generation. This is still very early. This is going to continue to improve as long as it's there. And this was an interesting case because we sort of managed it slightly differently. The patient didn't want to go out without anything to chew on, so we agreed to do it this way. But once those implants are integrated at 10 weeks, so I've done that lift and I've only left it for 10 weeks from a position in which we probably have residual bone 2mm. But I'm comfortable and confident with that lift and with the bone that's there. We've gone and activated that distal implant and essentially used the EthOss and these contact sites as well. So just a couple more cases. One example of doing a sinus lift and it not going very well. Problems do happen from time to time. Issues can arise. So in this case, just cleaning the socket and I caused the perforation. So what do I do in this case? I put a little collagen sponge into the area of the defect after lifting the membrane, and then I cover with EthOss, and then we just leave it for 12 weeks, and we come back to use it. We come back to use that sort of upregulated healed bone at a later point when it's easier to use it. Now, if we just look, that's it when we then open it, and that's it with a 5mm osteotomy drilled through all that area that was previously EthOss, and that's looking, behaving, and feeling exactly like bone, and we just followed a normal protocol for that, for doing an internal sinus lift. And if you look as well, you can see with these arrows how we've actually improved the sort of medial contour of bone on that upper left 7 as well. Those arrows in the same place on that image. You can see we've got a better area to work with now. So one of the things, just before we come to the end, is I'd just like to run through and show a few slides from our colleagues around the world. And part of this comes from what we have as the sort of EthOss Facebook community group, and this is something that I invite you all to join. So Facebook, social media, one of the only reasons we use it in the UK, or I feel I use it, is for this EthOss group. It's a nice way for dentists anywhere to post and ask questions and put cases up. So one example of a nice case here, we've got Tina. She's same-day dental in Dubai, and this is a 2.5-3 year review of this case that was done. The upper right one, high smile line, not a lot of bone, or next to no buffer bone there at all. So once that tooth come out, there's nothing there. All of these cases done at this clinic are done the same day. So they take the tooth out, graft, and provide a provisional at the same time. So it's a very nice and impressive outcome to see that they can achieve all that doing it the way they do it. And the other thing is they're using an external hex implant. If I didn't see these cases from this clinic, I wouldn't believe that this was possible with an external hex, but it clearly is. And this is an example of an implant called a southern implant, and it has a nice connection direction change built into it. I'll just show you that quickly as well, just to explain it. This is where there's an angle correction of 12 degrees built into the implant. It's essentially done so that you don't need angle correction after the implant's gone in. But that soft tissue and that bone, if you remember what that looked like a minute ago, we had no bone sitting on the front of that implant. Now we've got plenty of bone sitting on the front. It's all there through the benefit of EthOss. A really nice buccal contour that's stable at 2 years. We've just lost poor Robert Ratty's face. But this is an example of a colleague in England. This is an example of using some bone block with EthOss as well. And the nice thing about this case is, can you see those fenestrations on the adjacent teeth? So the bone block goes in, and then the area around gets grafted. There's contour grafting there to try and improve the outcome for the bone block, but what also ends up happening is that we lose those fenestrations. So the material has benefited the fenestrations here, they're simply dissipated. Now, Dr. Aretti goes on to use the materials in a layering technique, and we can see nice build out of material there. Okay, another case. This is the final case to show, and then I think we have a coffee break. So this is an example of a sort of resorbed and atrophic anterior maxilla. When we look at that, there really isn't much that we can do without grafting. So this was done with R2 gauge, which is a guided case, and the implants were placed in the prosthetically correct position. And the bone generated around these sites, the EthOss placed in around these sites on top of the implants, held in place by something called a Regeneration eye cage. And you can see here in these images just how much material there is and just how much EthOss we've got there on the buckle. So at this point it's not looking its prettiest, but Ludwig goes ahead and closes that, and we see at 1 week, it's looking pretty good. And at about 10 weeks after the graft, it's looking very good as well. And then we come through, take these regenerative sort of space maintainers out. And once we've done that, we've got residual host bone sitting underneath them and a hugely improved ridge, which is now able to be restored. And if we just remember what those implants and the positions looked like before the grafting and before the stabilization with those rib cages, we can just see how much bone growth has been achieved for this patient. And then we go on and have it restored. There we go. So if you get the opportunity, or if you're on Facebook, please do join us. If not, or if you have Instagram, I mean, all these social medias come in trends. At the moment for us, it seems to be Instagram. We've got an EthOss page, and I've got my page as well. But thank you for listening, guys. Have you got any questions? That's it from me for now.